Okay, great. Thank you. And thank you, the providers that joined today. Let me make sure I can, give me 1 second. Can you see the presentation there?
Yes, looks good. You are transcribing. Well, it went away, but
I
it looks good.
Okay, thank you. So I do have, like Brig mentioned, alluded, a lot of slides, but many of these slides are very short. I just want to know before I start, within the HIV treatment or HIV prep, if there's any specific concerns or questions that you may have, because I may take a deep dive on them now and then go about my presentation, or I can just go and you can stop me and ask questions during it. So I don't know, Dr. Martinez or Diana, if you have any specific questions.
Not at this time. Thank you.
Okay.
I don't have any other at this time.
All right. Okay. Thank you. So I'll just start the presentation. So I'm going to focus on recognizing the need to screen for HIV and how we go about to do that, identifying candidates for HIV PEP or PrEP. We're not going to be talking about PEP, but if you have any questions, I'm happy to discuss them. And also, once we find someone who's diagnosed with HIV, what do we do? So the need for screening is very obvious, and I've seen it, unfortunately, on firsthand. And I'll show you two cases that I ran into a couple of years ago. And the first one is a 32-year-old Native American female who had multiple visits to the emergency department in the previous month before we saw her. And she was complaining of respiratory symptoms, basically, until she got to the point that she needed to be admitted to the hospital. Actually, when she came into the ER, she was transferred to another hospital in Oklahoma for higher level of care. And then after she was stabilized, they sent her back to us. And when we got her in our hospital, we were looking at this X-ray, which looked like like a viral pneumonia. This is before COVID. It wasn't a typical pneumonia, and we looked, has this patient been screened for HIV? And the answer was no, after multiple ED visits and even been in another hospital. So we did screen her, and lo and behold, she was positive, and she had a very low CD4 count, and she struggled through that admission. I think we had her for about a month in the hospital. Finally, she went home. She was the first patient in Oklahoma that I did a home visit on because she was too sick to come home, and she lived far away from the hospital. But anyways, the message here was all of this could have been prevented if she had been screened and started treatment before she got to be so immune compromised that she developed pneumocystis. Back then it was called Cariniae, now it's called Jirovecii, but same bug, pneumonia. And this was another fellow who was incarcerated and had been brought from the jail to us meaning our health system, several times, two ED visits in the last month. He was complaining of headache and fever, and nobody did an HIV test. We got to see him in the ER. He was HIV positive, and he had, unfortunately, a cryptococcal meningitis. Up here you see the cryptococcus on the CSF stain. And unfortunately, this patient died. He had disseminated cryptococcosis. And when we looked at the chart, in this health system, he had multiple encounters with the health system and never been HIV tested. And that's when we started our HIV program more robustly at Cherokee Nation. And now we're in a better shape than we were before. Almost 85% of the population has been screened. But I just want to bring this as a highlight. The other thing, when we look at CDC data, the last one that I've been able to capture from up to 2022, a couple of things are noticeable. That the diagnosis of HIV are increasing in the population age 24 through 44. And they're stable or decreasing in the other age groups. So if you have a screening program, or if you want to start a screening program, ideally you have to screen everybody older than 13 and up to 64 by CDC guidelines, but you really need to focus that this age group is targeted. and that you don't miss anybody on this age, because that's where we're seeing more cases of HIV. The other thing is when we're looking at ethnic distribution of HIV new infections, unfortunately, American Indian, Alaska Native have had an increase of 30% of HIV diagnosis from 2018 to 2022, compared to most of the other Black African Americans are decreasing, the whites are stable, multiracial are decreasing, and there also is an increase in African American and Native Hawaiian and other Pacific Islander population, but the Native American is increasing. So we need to focus on the population that we serve to make sure that everybody has an HIV test done. The other really concerning aspect is when you look at, on the right-hand side, when you look at what is the acquisition cause of HIV in females, Native American females, 37% are due to injection drug use. This is astronomical. Just to put it in perspective, when you look at the US population overall, it's about 6 or 7%. When you look at countries that have really robust syringe service programs, it's less than 1%. And here we're seeing Native American females, 37%. So there's a lot of work to be done, and we need to make sure that all our females are screened, and also intervening with prevention strategies. And this is just to show that mortality equals to inequitable healthcare access or delivery. So not everybody, I had a teacher that told me once, everybody is equal, but some people are more equal than others. And you can see this on the map. The mortality is different depending on the state that you are. The darker the color, the higher mortality of people diagnosed with HIV. So we need to make sure that the population that we serve has access not only to screening, but to prevention strategies and treatment when they are found to be HIV positive. And this is just comparing Native American population with overall US population. And we can see that when we look at what percentage of people know their status of HIV, meaning if they're positive or negative, 87% of the overall population knows it, compared to 77% of the American Indian, Alaska Native. Then when we looked at received some HIV care, it's only 76%. Were retained in care once they were diagnosed, only 54%, and were virally suppressed at some point, it's only 65%. So there's a lot of work to be done, not only on screening, but also on engaging in care, maintaining people in care, and virally suppressing people with HIV. So I'm just gonna go briefly over some of the basic physiopathology of HIV, how it affects our bodies, and how do we go about treating it. So HIV is a retrovirus. Here on the right-hand side is the first electronic microscope photograph of the HIV virus that was taken. There's a long and very interesting history about this, which I don't have time to go over, but this was actually found by a French investigator in 1985 or late 84 called Luc de Montagnier, and he got the Nobel Prize for discovering the HIV virus. The top little round ball, blue ball, is the virus, and the bottom big, larger circle is the T lymphocyte. And that's the cell that the virus has a predilection for infecting and destroying. And the problem is that these T helper cells, these lymphocytes, are the one that gives us immunity or protection against an array of different types of infections, bacterial, fungal, viral, and also it protects us from tumors, from cancer. So if you get rid of these cells, like the HIV virus likes to do, then we lose our capacity to combat infections and also cancers. The problem of why we can't cure HIV is depicted in the slide on this graph on the right-hand side, this picture, is because the HIV virus, as you know, it's an RNA virus. When it infects the cell, there's an enzyme that the virus has called reverse transcriptase that changes that RNA into DNA. And that DNA, it's the red one here, it's incorporated in the human DNA. So this is a human cell. This is the virus who came in and turned their RNA to a DNA and incorporated on it. And many of these cells are sleeping, meaning they're not replicating. When we use antiretroviral therapy, we can only target cells that are multiplying, that have activity in their DNA replication. And that's why even we can use antivirals all we want, we will keep the virus at bay, but we will not be able to kill all the cells, all the viruses that are in our cells. And that's why we can't cure it as of today. There's a lot of research ongoing to see how we can wake up these cells and target them for destroying the virus, but we haven't achieved that. Now, we can suppress the virus, meaning we can keep it, our plasma out without any virions, but there will still be some cells that will have the virus in them. And this is a simple graph of the evolution of when an individual gets infected with HIV. So if you look here, you get infected and you may or may not develop what's called an acute retroviral infection, which I'll go over it in a minute. But after that, you recover spontaneously, and the disease goes silent for many years until your CD4 cells, which are depicted in this line here, the black line, start decreasing. Those are the cells that the virus destroys slowly but surely. And once you get below a certain level of CD4s, the magic number is about 200, that's when you start developing all these infections and tumors. But you have several years in which the patient will probably not have many symptoms. And that's where we need to make sure we test these individuals so we can diagnose them and put them into treatment and prevent this line going down. Because once you start patients on treatment, their CD4 goes up dramatically and very impressively, and they will not be affected by any of the complications of HIV, meaning they won't have AIDS. They will only have be HIV positive, but won't have AIDS. So this is a summary of what I just said. You may have symptoms initially, an acute retroviral syndrome, which I'll go over in a minute. And then you go into a clinical latency for years. And when your CD4 starts dropping, it's when you start having the systemic symptoms like fatigue and weight loss and maybe thrush. And then you have this more severe infections. And unfortunately, I still see them. I work at UNM many weeks a year as a consultant, and I still see every time I'm there a patient that comes in with cryptococcal meningitis or with PJP pneumonia or with CMV retinitis, and they've never been tested before. And it's really sad that we're still seeing that. Okay, a little bit about acute retroviral syndrome. It's usually missed, and that's the problem. And why? Because if you can see, the presentation is fever, macular papular rash. Many times it's just a sore throat. So guess what? These patients come in, they get swabbed, you have strep or you don't have strep, they get treated for that, and they don't test them for HIV. So anybody with lymphadenopathy, fever, pharyngitis, rash, myalgias, or any itis, any inflammation that you do not know what's causing it, you should check an HIV test. Same applies for syphilis. I mean, this could be a patient showing up with secondary syphilis and it presents the same way. And it's usually missed. I would say that 80% of the times it's missed. But when I ask patients that are newly diagnosed, the other day I had to go to the ER. Actually, I was in Tahlequah, and I went to the ER to see a patient that was just diagnosed with HIV, and he was diagnosed because he was screened. We have a lab trigger screening system. But when I was asking him, he was negative a year ago. So, and he described the syndrome. Oh yeah, 3 months ago, I had lymph nodes in my neck, fever, a rash. I went to the doctor. They checked me for syphilis, which was good, but they didn't check him for HIV. And this fellow was men with sex with men, high risk of HIV, and he wasn't tested. So when you go down that path of not being diagnosed and your CD4 cell counts are dropping dramatically, you get to the point that you start developing these opportunistic infections or tumors. And here's a list that is very useful of depending on what your CD4 count is or those T cell 4 counts are, that's what you're probably at risk of getting. And why is this useful for a clinician? Because if I see an HIV positive patient, a patient who's HIV positive, persons first, and who comes in with fever, and he has a CD4 done recently, or I check a CD4 and he has above 500, it's very unlikely that he will have any of the severe opportunistic infections. But except for tuberculosis, that's the only one. But if their CD4 is between 200 and 500, they can have candidiasis. If it drops even further, then you have the pneumocystis pneumonia. If it drops even further, then you have other complications like Mycobacterium avium, Cryptococcus, histo, lymphomas, etc. So going down the list, the more immune suppressed they're getting, the more higher risk of developing these complications. So to prevent and not see ever again all that I just showed you, we have HIV prevention strategies. So testing is the first one. Make sure you know your status, because even if you do have HIV, we can put you on treatment immediately and you will never see these complications. Second is you're HIV negative, then we can offer you PrEP if you're at high risk of acquiring HIV. PrEP is not for everybody, but if you meet criteria, it's a great option to prevent HIV. If you have been recently exposed, and there's an option for PEP, meaning post-exposure prophylaxis. It's a 30-day treatment with 3 antiviral drugs. PrEP is 2 drugs that you take while you're at risk of acquiring HIV. We miss PEP a lot, meaning we miss opportunities of offering PEP to patients. The biggest one that I can think of is people who are injecting drugs, are sharing needles or paraphernalia, and come in and they've shared it in the last 72 hours, and they're at risk of acquiring HIV. And as I told you, Native American females, 37% acquire HIV through injection drug use. So it's important to have PEP in mind for those as well as PrEP. Then education, be culturally sensitive and appropriate, counsel on risk reduction, and you will be able to offer your patients a happier life from a health point of view. So there are many HIV screening guidelines. I'm showing you the one that I like the best. And okay, I'm guilty that I'm biased because I work for Cherokee Nation. But the main difference with the CDC and the other guidelines is that we don't look for risk. We just look for age. And if you are 13 to 54, you get screened every 3 years. You'll get screened sooner if you have a high risk, and we know about that risk. And when you're 55 to 64, it's every 5 years. Now, why did we do this? Because nobody's asking about risk. Patients come in, they come in for a diabetic visit. Nobody's going to ask them about their sexual encounters and if they have high risk of acquiring HIV or not. That's the reality. Ideally, in the ideal world, yes, we would do a sexual history with every patient, but it doesn't happen. So we opted for just let's screen them more frequently and make sure that if they get HIV, we catch them at that point in which their CD4 count is above 500 or at least above 200, that we can change their lives in a better way. So, our guidelines are like the CDC, except we screen more frequently. So the tests, and you probably are familiar with all the tests, but there's antibody tests that stand alone. We usually don't use these, but now we're using them a little bit more because many of the point of care HIV tests are antibody tests alone. They don't have the antigen component. And they're great for their purpose of testing people in the community that you can't reach them in another way. Now, there are fourth generation tests that are point of care also, so you can use them. And the difference is that these tests pick up IgM antibodies against HIV, IgG antibodies, and also the antigen. This protein here in the surface of the virus is the antigen, and that's detected by the test. And then we have the RNA test or the nuclear test. Those are the most sensitive and probably specific. That's when we're looking for the RNA virus in the blood of the patient. Now, they're expensive, so we don't use them for screening, except in very specific situations that I'll mention later. You have to have in mind that the time to positivity of these tests vary. The RNA is the one that will pick up infections the fastest, within 10 days of an infection. But then comes the antigen. It's usually within 2 weeks of an infection. And last but not least, the antibodies takes about 3 weeks until you can detect a new infection. And here's a graph that shows you that. So you see the blue line is the HIV RNA. Within 10 days of infection, you can detect that. The HIV antigen or the P24 antigen, You can detect it with the fourth generation test, either point of care or lab test. That's about 2 weeks after. And finally, the antibodies, it takes about 3 weeks for them to be positive. So the eclipse period is those 10 days in which there's no test to detect HIV. And when is this important? And when someone tells you, oh, I've been exposed to I think I've been exposed to HIV, or I know I've been exposed to HIV in the last 10 days. So a test there is not going to help you. It gives you a window to intervene. If it's within 72 hours, you can do PEP, which is post-exposure prophylaxis. And after that, you just need to wait a little bit more until you can actually diagnose the infection. This is the algorithm. I get tons of questions about that because it is a little bit convoluted and complex. But the bottom line is this. You screen with a fourth generation test, which is the HIV antibody, IgM and IgG, and the antigen. That's all included in the test. If that test is negative, for the most part, the patient does not have HIV unless they are in that eclipse window in which no test is positive, or you've tested them too early, within the first 15 days of exposure. But if it's not that, then the test should be positive. When this test is positive, we have changed. In the past, we would do Western blot. Now we just do what's called an HIV-1, HIV-2 antibody differentiation immunoassay. And that's just, it's another test to detect HIV-1 and HIV-2 antibodies. And if it's positive for any of them, the patient has HIV, that's confirmed. You don't need any other confirmatory test. But sometimes you get an indeterminate test, like the first one's positive and the second one's negative. And that's when you reflect to an HIV nuclear test or an RNA test. The only thing I want to mention is that HIV-2 is rare in the United States. Less than 5% of the people have this virus. It's mainly on the west coast of Africa. But the HIV-1 that we do normally does not detect it. So if you're suspecting that because the patient's been, maybe they're sexual partners from Cameroon, or they or they traveled, or whatever circumstance, then you have to do an HIV-2 RNA to confirm. That's a special test. So you screen, you do the confirmatory test, then you do the RNA, not to confirm, it's just to get a baseline viral load before you start treatment. And then you discuss with the patient what the plan is for their treatment. So the most important thing, it's hard to give a report of a potentially serious disease. It's not as serious as it was in the past. 35 years ago when I started my career in doing HIV, an HIV test was a death sentence, basically, a positive HIV test, especially if the patient had AIDS, and those were the ones that we were testing because there was no treatments. Today, it's just another chronic disease that has better outcomes than most of the other chronic diseases that we take care of. Better outcomes of congestive heart failure, COPD, than many cases of diabetes. As long as the patient takes their medication, they will be fine. And that's the important message you need to deliver in those crucial 10 or 15 minutes that you're telling the patient that their test is positive. For that, you need to build rapport. Sometimes it's difficult to build rapport in 5 minutes. But as long as you show empathy to the patient and that you really care about his condition and that you're willing to help, that'll break the ice. And although the shock will not go away on that day, the next visit you have with them is usually a much better encounter, and the patients have accepted the situation and are willing to move forward with treatment as you have recommended. Try to eliminate stigma as much as possible. That's one of the biggest barriers that we have. Educate and emphasize the importance of being on treatment. It is interesting that today there are a handful of patients that do not want to get treated. The majority do. But when I always tell them the anecdote, when we had the first decent treatments for HIV, we had lines of people trying to get these treatments. Nobody was not wanting to get treatment. But now we have a surplus of treatments and there's people that don't want it. So that's beyond my comprehension. But I just wanted to mention that building a good rapport with the patient usually cuts it. So this is, again, patient relationship, education, confirmatory labs, and treatment initiation as soon as you can. This is a list of labs. I'm not going to go over them in detail, but I can answer any questions you may have. The only thing I want to mention These are the labs that we order when we start treatment or before we start treatment. The HLA-B5701, you don't need to do that test if you're not going to use the drug that's called Abacavir. And we usually do not use this drug in the majority of patients. So you can save money on that. All the rest, the CD4, the viral load, the hepatitis serologies, TB testing, STI testing, all that goes. And one test that I don't see here, I think I missed it, will have to include it, is the genotypic resistance, or the genotype. You need that test because you need to know if the virus is resistant to any of the drugs that you're going to offer the patient. We treat everybody, or we at least offer treatment to everybody. We tend to start as soon as possible. There was really good data at CROI, which is the antiviral conference this year, in which the sooner you start, and sooner maybe even weeks difference or days difference, that the immunologic response on that patient is much better. They'll do much better in the future if you started them quickly on treatment. And I try to start them on the same day. Even if I don't have all the other labs yet, I draw them, send them out, and start the patient immediately on antiviral therapy. So we have 4 classes of antivirals: the nucleoside reverse transcriptase inhibitors, which are the oldest ones and the most common ones, and we have a lot of experience. Example is tenofovir and emtricitabine. You may know that as Truvada or Descovy. And then we have the integrase inhibitors, which are the recommended treatments, and it's either dolutegravir or bictegravir. And then you have the NNRTIs. I'm not going to spend any time on this. There are some really good drugs on this group, but we don't really use them as first-line therapy. And then the protease inhibitors, which are very good and potent, but we don't usually use them as first-line therapies unless there's a special circumstance. And this is just a cartoon of the virus, how it enters the cell, how it changes the HIV RNA into human DNA. That's where the reverse transcriptase act. And then that DNA is integrated into the human DNA. That's where the integrase inhibitors act. And then before the virus leaves the cell, that protein, that long polypeptide that was synthesized, needs to be broken down. That's where the protease inhibitors act. That's where the different actions of the medications we use. The recommended treatments are bictegravir or dolutegravir in combination with tenofovir and emtricitabine, which is FTC. And bictegravir can be done in 1 tablet daily. Dolutegravir is a separate tablet combined with TAF and FTC. And this is the go-to treatment, I would say, in 95% of the patients that we start on treatment. If there's any contraindications to the drugs in this first regimen, that's where the dolutegravir, abacavir, lamivudine kick in, but we don't usually use it. And the use is when the patient has severe renal insufficiency. Let's say they have a GFR of less than 30. That's where we would use this drug. And for some patients, we can use a 2-drug combination instead of 3 drugs, which gives you less toxicity. But these patients have to have a low viral load, less than 500,000. They have to be negative for hepatitis B virus, because these drugs don't act against hepatitis B virus. And and you need to make sure that they don't have resistance to any of these 2 drugs. So if they meet those 3 criteria, you can start them on a 2-drug regimen. On patients who have CD4s that are low, when you diagnose them and start treatment, you will have to give them some antibiotics to prevent the infections that are listed on the left-hand side of this table. And here are the CD4 thresholds and what drugs you need to give. Usually the go-to drug is Bactrim, double strength daily, and that will cover the majority. And actually, if the patient, we don't use the azithromycin anymore if we're starting them on ART. And fluconazole, it's only if you live in an endemic area for histo, like Oklahoma, sometimes you use it. And crypto, only if they have a crypto antigen that's positive. But the majority, it's going to be bictegravir combination with Bactrim for most patients with less than 200 CD4 cell count. Okay, I'll stop there for a minute because I'm going to shift into HIV prep. I don't know if there are any questions that you may have here.
Jorge, this is Diana. Quick question on the HIV genotype.
Yes.
Can you explain the reasoning behind that testing?
Yes. Yes, certainly. Thank you for that question. So the HIV genotype is it's also called genotypic resistance. Okay, so let me clarify. There's two types of genotypes. One is to see if this is HIV 1 or 2. We don't usually do that because the majority are HIV 1s. But if you run into an HIV 2, you'll have to genotype. The genotype that you're talking about is the genotypic resistance. And that is when it's a laboratory test that we send out. And then the results that we get are if the virus that this patient has is resistant to any of the antiretrovirals that I just mentioned. So let me go up. Give me 1 second. For example, in this case, if you started the patient on bictegravir or dolutegravir with TAF and FTC, that result will tell you it is sensitive to these drugs and it's okay, keep the patient on the same drugs. But let's say I started the patient on bictegravir or dolutegravir, and when I get the resistance results back, it says it's resistant. Then you have to change the treatment immediately. But you have time. You have a couple of weeks to do that. So usually I see the patient, I order that genotypic resistance, I start them on the bictegravir. That's what I use most because it's a 1-pill regimen. The dolutegravir, it's a 2-pill regimen, but you can use any of those. And I start them on treatment, and then I wait for the results. When the results come back, I just make sure that they match, meaning that what the antiviral that I'm giving that patient is adequate, and bingo, you just continue giving them that treatment. But if it shows any resistance to the drugs that I gave that patient, I'm going to have to reformulate my treatment strategy. Does that clarify it?
Yes, thank you.
Yeah, and usually they'll give you resistance results for NRTIs, which is tenofovir, emtricitabine, for the integrase inhibitors, which is the dolutegravir, bictegravir, but they'll also give you the resistance for the other drugs, like the protease inhibitors and the NRTIs, in case you need to use one of those drugs. Okay. Any other questions?
I had one, Jorge. If you could maybe spend just 60 seconds, because I know you have a lot of prep slides to go. Could you mention any kind of ways that you've streamlined testing? You mentioned a lot of regular HIV screening. How have you streamlined who orders the test, consenting patients, or anything to share that's worthwhile?
Yeah, so what's worked a lot, very well for us, but you have to make sure your systems is on board, is what we call lab trigger screening, meaning a patient comes in for whatever reason, and they get a blood drawn for whatever reason. The electronic health system checks if they have been tested. I mean, if they're due for HIV, based on our criteria, every 3 years, depending on your age. And if you're due, the electronic health record, not the record, the system generates an order for an HIV test. And it also checks if the patient has a signed informed consent. And our yearly informed consent specifically spell out HIV, Hep C, and syphilis. So if a patient comes in and they have signed that informed consent and they have not opted out, when they sign the informed consent, you can do the test. And we've screened like 85% or above our population doing that. The only caveat is that if you're not doing a truly opt-out every time the patient comes in. So the patient may have signed that informed consent in January. Let's say they come in June, and maybe in June they don't want to get tested. Well, if that system is not verbally asking them. Now, we had a problem, not with HIV, actually it was with syphilis, and we had to stop doing that. And we went to a system in which the nurse or someone will ask the patient the question, but it all depends how they ask the question. And when you look at the literature, there was a really good study done, published in JAMA, of HIV testing in the emergency department using several methods. When you ask patients the opt-out questions, 30 or 40% will say no. And most of the time, it's because the question is being formulated in a very negative way, or the patient's not being explained properly. Why you're doing that? When you ask the question the right way, 95% will say yes. So I think this is a personal opinion of mine. I don't think we should use opt-out anymore. I mean, we don't opt out patients for a glucose test, right? And then if it comes high, you tell them you have diabetes. And you're giving them a chronic disease diagnosis that requires a lot of treatment and follow-up. the same way as HIV. I mean, opt-in and opt-out were implemented in the times that we did not have good treatments. And I can understand in 1985, if I want to do a test that implies a death sentence in the next 6 months, maybe I don't want to get the test done. And that's fine. But we're not at that point. We're at a point that taking a pill a day, you can live a normal life the rest of your life, not only normal in your health, but you're not transmitting the infection to anyone. You know, you close you undetected is untransmittable. I think that times have changed and we have not kept up with those changes. But, you know, we still have opt-out being recommended by all the states, and I think that needs to be changed.
Thanks. Excellent. Okay, you're at 42 after the hour. Carry on.
Okay, so on HIV PrEP, I will be brief, and I'll just skip some slides, but you'll have the slides anyways. So HIV PrEP basically is someone who's HIV negative, but is at high risk of acquiring HIV. You offer them an antiviral that they take a pill a day to prevent HIV. That's the gist of it. And if everybody who's at risk would do this, we probably could eliminate HIV from the United States or from wherever place it's being implemented. I do want to highlight that there are many ways to prevent HIV, and PrEP is just only one of them. You know, condom use, changing your sexual behavior to make it less risky, etc. But I'm just going to focus on the pharmacological intervention, which is HIV PrEP. And I'm not going to be talking about PEP today, but that's the other one that we use. So is it effective? Yes. If you take your pills every day, 99% effectiveness, meaning 99% less risk of acquiring HIV than if you don't take the pill. And if you're injecting drugs, 74% effectiveness. So the bottom line is to detect the high risk. And this is a pretty simple way of doing it. If so, for sexual risk, ask the patient, in the past 6 months, have you had sex with, first, have you had sex? The answer is yes. How many partners have you had sex with? And then what are the genders of those partners? Why? Because if you are a man who has sex with men, the risk is higher than if you're a man or a woman who has heterosexual sex. And then do you use condoms? And this is the critical question, because I don't care what sexual behavior you have, but if you always use condoms, there's no risk for HIV. You can have sex with 20 men, different men, but you're always using condoms, you're not at risk. And the other question is, does any of your partners have HIV? I included this question, but the reality is that nobody really knows the HIV status of their partners in general, unless it's a stable relation. So it boils down to, do you have sex with more than one person, and do you use condoms? And the drug injection behaviors, basically, are you sharing drugs with anybody? Because if they're not sharing drugs, that's not a risk for HIV. I mean, I'm sorry, if you're not sharing paraphernalia, needles, syringes, cookers, etc., you're fine. So that's the question you have to give them. And the time frame is in the last 6 months. Now, the other one that really should raise a flag is if you're seeing a patient with any STI, gonorrhea, chlamydia, syphilis, etc., that's a patient that you need to take a deep dive on these questions and make sure that that they're not at risk. And the one that I don't think is included here is, do you have sex under the influence of drugs? Why? Because you may not be using prevention measures like a condom, like you would if you were not under the influence of drugs. So basically, sexually active people or people who inject drugs, if they've had any of the items I've mentioned before, they would be good candidates for HIV PrEP. If someone comes and tells you, I want HIV PrEP, and when you start asking them questions about their sexual activity or injection drug use activity, they don't want to tell you anything. That's fine. That's their own privacy. But as long as they understand what HIV PrEP is for, then just give it to them, because maybe they don't want to share their personal lives with you, but they understand what this is for and they need it. And that's an indication to give it to them. The main thing, you need to make sure they're not HIV positive already, because if you put them on this true drug regimen and they're HIV positive, they're going to become resistant to those drugs. Also consider if they are candidates for PEP. If they've been exposed within the last 72 hours, either sexually or through injection drug use, you should start with PEP and then transition them to PrEP. And there's a lot of labs that you need to do on that first visit. And a clinical assessment is basically if they have any kidney issues or any bone demineralization issues like osteoporosis. So this is the easiest and the one that we have the most knowledge is Truvada, which is tenofovir disoproxil, 1 tablet a day for all patients. GFR has to be above 60 though. It's important to know what their hepatitis B status is, because if they have chronic hepatitis B, you can use this because tenofovir acts against hepatitis B, but you need to now tell the patient that they shouldn't stop the drugs or they can have a flare of their hepatitis B. But it can cause some, on the long term, some bone effects and some kidney effects, and you need to know that. The SCOBY, which is tenofovir alafenamide, is less toxic. You can use it with GFRs above 30. It has other side effects like increase in weight and some lipid abnormalities, but you should only use this if you are a man who have sex with men or a transgender woman. If you have vaginal sex, this is not the drug for you. You can use it, but it's not been as well studied as Truvada has on that population. And finally, you have the injectables, which you give 1 month, one injection once a month for 2 months, and then every other month you continue the injection. It's cabotegravir. It's an integrase inhibitor. Renal function is not relevant. Hepatitis B status is not relevant. The only caveat is that the patient has to come to the clinic every 2 months to get their shots. They cannot get their shots at home. That's the issue with it. So this is one that's on our national formulary and the preferred one, preferred in the sense of ease of use and experience. But in reality, in my opinion, if the patient can afford or has insurance that covers cabotegravir, that's probably the most effective because they have the drug on board for 2 months without having to take a pill every day. The problem is the cost, $10,000 a year compared to $200 or $300 a year with Truvada. There's also what's called PrEP on demand. And those patients who are not having sex frequently, they just want to take a pill when they have sex. So you take 2 pills of Truvada 2 to 24 hours before sex, and then 1 pill on the next day and another pill on the 3rd day, and then you're done. And it's not as effective as taking pills daily, but it does work and it decreases the risk. I'm going to skip this for now. And then this is just a table of the follow-up. You basically need to see your patients every 3 months and do some testing, which includes blood for renal function and HIV testing every 3 months for sure. And STI testing depends on the risk, exposure, and on the type of patient that you have. When you discontinue PrEP, you need to be very careful in making sure the patient knows that if their behavior hasn't changed, they're at risk of acquiring HIV, and you have to explain other options for them. This is just to show you for those providers that are worried, oh, I'm going to have to document a lot. Well, we have auto text that can make your H&P go really fast. And we also have pre-formed lab orders that makes it very easy, and you don't have to start typing each lab each time you send the patient. PrEP can be nurse-driven, can be pharmacist-driven, or provider-driven. And that's something that depends on your system and what works best for you. Any of these do not work best in all the systems. It's not one fit all, but you need to explore what's going to be easier for your system to deliver. And then when someone tests positive for HIV, because it does happen, usually in my experience, is patients have stopped PrEP, they don't tell you, they come back, you test them, they're HIV positive. So have a compassionate disclosure, build rapport, destigmatize the situation, and tell them that, okay, you have HIV, but we got really good treatments that will make your life seamless in this regard. And as long as you take your medications every day and make sure you support them through that journey. And this is at the end of the PrEP talk. The only thing I want to mention is that there are some new kids in the block that are very exciting. that were presented at CROI, and I just want to show you one slide, which is this slide, lenacapavir. This is an injectable PrEP that you do this once every 6 months. And there's several trials. The good thing is this, the company that produces this has 5 or 6 called purpose trials. So they're looking at men who have sex with men, cisgender women, transgender men, transgender women, people who inject drugs. So they have studies on all these populations, and all so far are looking really good. The problem is going to be the cost. So it's being evaluated by FDA right now, and it's probably going to be around $10,000 a year, my expectation. And probably I would reserve these treatments for those patients in which compliance is actually an issue, or their insurance covers it. And I'll stop there, and I'll give you the slides so you can have them, of course. But I just want to know if there's any other questions.
Dr. Mera, it's Diana again.
Yes.
Have you seen the compliance, to the treatment, the homeless population versus someone who's actually has housing? I mean, are there any programs that you've seen successful for outreach to them? And due to high risk, I mean, there's reasons why they're homeless, and there's actual behaviors that are occurring because they're homeless. So do you have any ideas on that?
Yes. Okay. So I don't have, I mean, I do have personal experience that because we started a year and a half ago, reaching out to harm reduction sites, to homeless shelters, peer recovery sites. And yes, like you mentioned, it is a problem with adherence. And many of these patients, unfortunately, don't even want to be started on PrEP. I think that it is a challenge. You need at least make sure you're offering it to them, even if they don't take it. For men, even if they don't take a pill every day, even if they take 3 or 4 pills a week, it still protects them. And there's some new data that even if you take 2 pills a week, it still protects you. So I think we have to use our imagination with these populations, and maybe have community health workers, and especially peer recovery specialist workers, going out there and even trying to do some direct observed therapy, or reaching out to them frequently and making sure they're taking their meds. I think it is a challenge. We shouldn't throw the towel. We should do the best we can. Now, when lenacapavir comes along, that's going to be a game changer if we can access the drug. The problem is going to be the cost. Because if I can give a shot and I got that patient protected for 6 months, bingo, that would be the ideal situation. But we'll have to see when it comes up, how much it costs, who covers it, who buys it. And I would probably use it, especially on those high-risk populations. Like if you go to a homeless shelter, let's say you see 10 people, and you'll find that 3 of them are at risk of HIV. That would be the ideal drug to use. Give them a shot, then you've got them covered for 6 months. Right now, all we have is Truvada, and we're using it as much as we can, but there are adherence issues. There are even adherence issues on even shorter treatments that we're trying to get.
Thank you. I have a question, but first I want to do some housekeeping. Alicia, if you want to put up the survey, the end of session survey that folks can click through. I don't know if Alicia, if you have anything else to add to that.
Nope. Thanks, Brig. The survey's in the chat. Just take a couple minutes to complete it, and every time you do a survey, you'll be entered in for a raffle that we'll do at the very end of all the sessions. So thanks so much. We appreciate your feedback.
Thanks. My question, Jorge, is sort of how it's played out for you in New Mexico and Oklahoma. Do your PrEP services tend to get centralized onto one medical team that's very familiar and comfortable with it? Or do you have kind of a lateral, most medical teams are PrEP literate, able to give the service and see patients?
No, that's a great question. So what we've tried to do in each clinic is detect a few champions. It's very hard. Same thing happens with hepatitis C treatments. Not everybody wants to adopt this. Not sure why, but not everybody wants to adopt it. But you don't need everybody adopting it. As long as everybody is on board in detecting the risk. So let's say a provider says, oh, this patient is a candidate for PrEP. Even if they don't want to do it or don't feel comfortable doing it or whatever, As long as they have someone in the clinic or pharmacist or a nurse, if it's nurse driven, or another provider, if they can have them see that patient and start and get them started on PrEP. So in Cherokee Nation, that's how it's working. Each clinic has one or two providers. In the past, we had pharmacists. Now we don't have them anymore to do that job. Providers that will do PrEP and the same providers that do hepatitis C treatment, et cetera. That's how we get the job done. Of course, if you have everybody wanting to prescribe it, that'd be wonderful.
Great. I'll start to close this out. I want to remind everyone that we do have office hours with Dr. Mera tomorrow at the same time, same Zoom link. That Zoom link will also go out in a post-session email to all the registrants, so you will have it in your email box.